Welcome to Back from the Abyss. I'm Dr. Craig Heacock. Today, Back from the Abyss is on the road. I'm in Denver at the University of Colorado Medical School, and this is an interview I've been looking forward to for a long time. We've been getting a lot of listener requests to talk more about sex hormones. It's definitely one of my big interests, I think, as listeners know. And so I was looking, who in Colorado is the expert on this? And wouldn't you know, it's the chair of the Department of Psychiatry at University of Colorado, Dr. Epperson.
Hi, how are you doing today, Craig? It's great to be here.
Yeah, Neill Epperson, thank you. It's so fun. My wife said, why don't you just do these distance interviews on Zoom and not drive all the way down there? But it's so fun to meet you. And in fact, we looked at each other and thought maybe we'd met somewhere, but...
Just have a familiar face, I guess. Both of us.
we have that next door look. So this is going to be a deep dive into sort of all things sex hormones and psychiatric illness. But maybe we could just start, just give us a thumbnail of your research interests, what you're most interested in psychiatry, what you've been studying.
Sure. Well, my interest in hormones began a long time ago. I was a third-year resident at Yale at the time. And, you know, as a physician scientist, you're kind of in a very special situation where you meet people who present with various mental health challenges, and then, you know, you're also a scientist. So you tend to ask yourself, why is this, you know, mood disorder or these obsessive compulsive symptoms starting in the postpartum period, for example, in somebody who's never had mood disorders or OCD symptoms. And about that time, I was starting to realize that I really didn't want to be a private practice child and adolescent psychiatrist. I'm nothing against those. I'm married to a child and adolescent psychiatrist, but sort of my curiosity about the why people experience these kinds of symptoms, particularly at a time that, you know, women are very vulnerable in the postpartum period, and moms are supposed to be, you know, really connecting with their babies at that time. And if you're suffering from a deep depression or, you know, really experiencing even infanticidal thoughts that are horrific to you, that's not really conducive to mother-infant bonding. And so about that time, I realized that, you know, I wanted to be a scientist. I also had a patient with postpartum depression and postpartum OCD symptoms. And again, I really started questioning, why in the world is this happening at this time? And, you know, when women, you know, develop postpartum psychosis, it's often they have psychotic thoughts about the offspring, danger to the offspring. They may even think of themselves as potentially doing something dangerous to the offspring. And obviously that's not conducive to survival of the species. And so I just got fascinated by this phenomenon. And at that point in the 1990s, and in my education in medical school or residency, you know, nobody talked about how hormones affect the brain. You know, when you learned about estrogen and progesterone, you learned about it in relationship to the menstrual cycle, or if you learned about oxytocin, it had to do with milk letdown and uterine contraction. Now, of course, you need oxytocin to deliver the baby. You also need oxytocin to be able to breastfeed. But then I started reading books and manuscripts and papers, both preclinical literature as well as human studies. And it all of a sudden was so apparent that oxytocin and all these other hormones are so critical to maternal behavior, so critical to many aspects of behavior. And so with that, I started really studying estradiol, progesterone's neurosteroid derivative, allopregnanolone, and how it affects the brain and neurotransmitters that we know, or brain regions that we know, or systems in the brain that are responsible for so many aspects of human behavior. Our sex drives, our desire to eat, sleep, be with other people, you know, our mood, how we think about ourselves, whether we, you know, get traumatized and develop PTSD, our cognition. I mean, hormones are so profound. And so how can one not be super excited to get up every morning and think about, like, how am I going to study estrogen today?
I love that. I mean, yeah, I have to say, people who are just in love with what they are studying, I love that.
Yeah.
What do we know as of now about the why behind female sex hormones and psychiatric decompensation. So when I think of when do men fall apart, I think men, there's a big kind of surge of onset of mental illness in sort of mid to late adolescence, early 20s with bipolar 1, schizophrenia. And then, of course, there's a lot of men who kind of fall apart with sort of existential relationship, maybe testosterone issues later in life. But I think of women have all these times, like women, first girls often tend to decompensate psychiatrically after their menses, through the hormonal adolescent times, when they're pregnant, when they're having their period, after they have a baby, perimenopause, menopause. So there are all these hormonal shifts where it seems like we see psychiatrically women really struggling. What do we understand about the why behind that?
Well, I think it's a fascinating question that unfortunately we don't have a hard and fast reason. I think some of the things that people have to really focus on, it is, and this is work that I respect very much from Peter Schmidt and David Rubinow at the National Institute of Mental Health. They did a number of studies several decades ago and have continued in this work showing that it's not the level of hormones that people experience. Like, it's not because if I have PMDD, it's not because I don't make enough progesterone. It's not because I don't make enough estradiol. These hormones have such profound effects on so many neurotransmitter systems. For example, estradiol alone, I would dare you to name a neurotransmitter system that estradiol doesn't have some interaction with, either at a receptor level, an enzyme that is responsible for the conversion of a precursor to that hormone, or, a receptor, the amount of a neurotransmitter. I mean, there's so many aspects of these hormones and their effects on the brain that it's not about the level of hormones. And that was something that Dr. Schmidt and Dr. Rubinow really, I think, have shown us in very, very clear-cut terms in humans, that it is really about something in that person's brain, the way they respond to a normal fluctuation or a normal level of hormones that is leading them to having sort of a maladaptive response to those particular hormonal fluctuations. So it's not so easy as just saying, oh, here, you have this problem, let me give you back, I can draw blood and say, oh, you're deficient in this, let me give you back that and you won't have PMDD anymore. That's not really how this works. And so there are probably many different pathways that people can get to having mood and cognitive, sexual, behavioral symptoms in relationship to periods of hormonal flux. And I think that's why it makes it so complicated to know and answer that question. Why is this happening? We just know it happens, but for any one individual, it is very unclear for that person exactly why this might be happening. I mean, perhaps they have more ER beta receptors in a particular area of the brain that is responsible for mood, or less ER beta and more ER alpha, or whatever it might be. Or maybe that receptor is just not working quite as well. GABAergic receptors are also thought to be very important in fluctuations in neurosteroids, for example. So I think that this gets really to the uber area of personalized medicine that, again, for a single individual, we don't know exactly why they're experiencing these symptoms. We just know that, again, the hormones are triggering something in the central nervous system.
I was doing a case consultation yesterday with a psychiatric NP, and she's presenting an adolescent girl with suicidality and mood instability and cutting and just chaos. And I said to her, I'm curious your thoughts on this. I said, my sense is 20 years into psychiatry that this is arguably one of the most complicated groups of patients to quote unquote diagnose, because there's some percentage of the adolescent girls who are suicidal and self-harming and have terrible mood instability who are just going to, quote unquote, grow out of it. And I often sit with these parents and the kid and I say, I'm pretty sure this is hormonal neurodevelopmental, in sort of broad satellite-based view. And, you very well will grow out of this. And then there's some percentage of adolescent girls in chaos who will actually have a mood disorder.
Mm-hmm.
But, and I guess maybe that's what you're talking about. It's so much more complicated, kind of like the BS serotonin hypothesis of depression. We know that's so much deeper than that.
Yes.
And
Yes.
so I like this idea that the hormone, it's not just the hormonal milieu, but it's all the downstream effects are so profoundly complicated.
Absolutely. And I don't say this to make people feel despairing for some. I mean, I actually find that even when you give that kind of response to the parents and the child, look, I can't tell you exactly how to fix the hormones here because it's not the hormones' fault. I mean, the female brain has to be unbelievably flexible because we have these, like you said, after menarche and girls start menstruating, their brain has to change in response to these hormonal changes. I mean, it's just there's a fluctuation in the hormones. There's a fluctuation in how the brain responds to those hormones. And I've often seen, for example, even women who don't have premenstrual dysphoric disorder or severe PMS, I've seen onset of that in the postpartum period. And I've often thought, wow, there was something about the pregnancy and exposure to those high levels of hormones for 9 months. I mean, it's super high levels of estradiol, progesterone, changes in cortisol, changes in neurosteroids, changes even in the stress hormone cortisol during pregnancy. And then you deliver the placenta, and all of a sudden, within 48 hours, you're like a postmenopausal woman. I mean, how fantastic your brain has to be in order to be able to manage that level of hormonal flux and for you not to become psychotic or depressed or develop OCD symptoms. And so I've seen women who, after they start menstruating, after they've had a baby, all of a sudden they have onset of PMS or full-blown PMDD. And they often want to know, well, what happened? And I'm like, well, your brain had to change in order for you to be able to get through pregnancy, become a mother, and now, however, the brain your brain was altered by this experience, you're not able to tolerate as well the hormonal changes that are associated with menses, for example. So, again, it's very complicated and it's a whole lifespan approach.
Yeah. I tend to think of estrogen as both cardioprotective and neuroprotective, but I wonder, based on what you're saying, if that's actually a gross generalization to think of that estrogen is somehow protective of the brain or CNS, that it's so much more complicated. There's so many downstream factors.
Well, I think the animal studies, and again, most animal studies today focus on a particular kind of estrogen, estradiol. And then when we give hormone therapy to women, a lot of times it is estradiol that we are giving. And so 17-beta estradiol in animal studies does look to be neuroprotective, and in many ways, decrease inflammation, just the way, you can see, little connections, we call them dendrites, that are dendritic spines that are on nerve cells, and the projections from nerve cells that we know are important for connecting one nerve cell to another nerve cell in a healthy way, so that we get learning and memory, that we can function in our daily lives with ability to be organized, I'm sort of referring to our executive functioning. So we know that estradiol in these animal studies, both rodents and non-human primates, has really profound effects on brain regions that are critical to us being able to function as humans, particularly in this complex world. Bear with me. I'm going to talk a little bit about a study that I did,
Please do.
if you don't mind. And again, I'm not trying to do my own hormone on this one, but again, getting back to that personalized approach to thinking about hormone therapy. I was seeing a lot of women in my clinical practice that would come in with pretty severe cognitive changes after having undergone oophorectomy. That means just removing the ovaries. A lot of times women are having now, because we have better genetic testing to know who is at risk for breast and ovarian cancer, you have a larger number of women now undergoing what we call risk-reducing salpingo oophorectomy, so RRSO for short. Listeners, don't try to spell that. Oophorectomy has 2 O's. But in any case, if you actually see women who've undergone these procedures pretty early, so they're not even postmenopausal yet, you'll start to see like worsening of vasomotor symptoms, hot flashes, night sweats, but also sexual functioning, mood, and really some pretty significant complaints in the cognitive arena. But not everybody. So not everybody who undergoes a natural menopause around the age of 52 or one of these oophorectomies earlier in their late 30s, early 40s, not all of these women experience these symptoms. And so, again, my curiosity is, okay, why is the patient in front of me having such severe symptoms, and yet other people can kind of just go by their merry way? And as a psychiatrist, you and I both are in clinical practice, we know that a lot of psychiatric disease and a lot of things that go on with the brain that are suboptimal really have their roots in early childhood experiences. Were you raised in poverty? Were you raised in a nurturing family? And so I'm talking about sort of the social determinants of health. I tend to study adverse childhood experiences, pretty narrowly, whether you suffered abuse, neglect, maltreatment, or whether you had sort of household difficulties that are really been shown in multiple studies to increase the risk of a whole host of medical problems. And I thought, well, if they're increasing medical problems, I'm sure they're probably increasing psychiatric problems. And most people have known this for a long period of time, but I don't think people had really thought, well, is this one of the reasons that some women can go through these hormonal changes with gonadal steroids like estradiol and progesterone, but have a aversive effect with respect to their cognition, mood, particularly at times like, premenstrual, postpartum, or in the perimenopause. So I started thinking about childhood adversity having sort of creating a substrate in the human brain that then these hormones that fluctuate across the female lifespan are impacting. And so I did a study where women who underwent a natural menopause and were experiencing cognitive concerns. And they weren't depressed, because we know that depression can also increase cognitive concerns. So they weren't depressed, they were pretty healthy, and had no reason that they couldn't take estradiol. But I recruited a group of women that had higher levels of childhood adversity and compared them to a group of women that had really, almost perfect childhoods. Like most people have some adversity. So, and studied how their brain responded when they were in low estrogen state in the postmenopause to a very complex working memory task, where we basically really challenged them to be able to use their prefrontal cortex, which really supports our ability to be organized, to pay attention, to sustain attention, to get motivated to get up and go do what we need to do. And interestingly enough, when they were in the low estrogen state, the women with the high levels of adversity had to activate that part of the brain more to do just as well on the task as women with low levels of adversity. So they looked different. It was almost like, if you want to put it in lay terms, it looked like their nerve cells were working harder. And then I randomized them to estrogen for a period of time and a placebo for a period of time. And I looked at how the brain changed with placebo and with estradiol. And interestingly enough, placebo didn't really do very much with respect to the brain activation in either group. But then the group that had had the early life adversity, when they were on the estradiol, that particular brain region sort of dampened down. It didn't look like, we call it the bold signal. The bold signal was reduced. And so if you want to put it in lay terms, it's almost like they didn't have to activate that part of the brain as much to do the task just as well. And guess what? They didn't look any different than the women with low levels of adversity. It was almost like the estradiol in that population made them look like that they hadn't been exposed to adversity. Mm-hmm. And so what that says to me is that when we think about hormones, we have a tendency to want to say, well, everybody should be on hormones for their cardiovascular health, or everybody should be on hormones for their cognition. And guess what? Maybe that's not the case. Maybe the effects of our lived experience could make us more or less sensitive to how hormones affect the brain, and that we really need to think about this in a more complex fashion.
Is it fair to say that the female brain is more vulnerable to mood and anxiety disorders because of the sex hormone milieu, sex hormone, the estrogen and progesterone? Or again, is it way more complicated than that?
Well, I think it's complicated, and it's not like the male brain doesn't experience testosterone, and testosterone gets aromatized to estrogen, estradiol actually. So basically, the male brain also gets exposed to estrogen. The male brain also gets exposed to allopregnanolone, which is a metabolite of progesterone, because our brains are built to make some of these hormones. And that's the other thing that most people think of the gonads or our ovaries and our testes is where all the hormones come from. Well, guess what? Your brain is actually making hormones as well. And so I think the human brain is sensitive to these hormonal changes. And I feel like we're only getting to the point where we have some of the techniques and technologies in science to be able to study the human brain in a more sophisticated fashion. And the thing that I just keep really pushing is just not one size fits all. Just like, Peter Schmidt and David Rubinow showed that, if you're not quote unquote hormonally sensitive to these changes, then you can experience these hormonal fluxes and you don't get depressed, or you don't have, changes in behavior that are suboptimal, or, in your cognition. But if you are, it doesn't matter where you are in the reproductive lifespan, you're likely to have these kinds of changes that, at least in the world that we live in today, is suboptimal. It's suboptimal to be an executive, undergo an oophorectomy, and have huge cognitive changes. That's suboptimal in our world today. If you're, not working really hard with your brain, and your work is something that is more manual, you might not notice the changes that could occur in the brain, because your brain, you're not living, breathing based upon your brain, being able to do a huge, important task and multitask. So again, I think that we see lots of variability in how people experience these changes. And I think that one's lived experience, not only your childhood adversity, but how healthy are you now? I mean, we know that these hormones impact the immune system. We know they impact the gut. We know they impact the heart. And so how healthy are these other organs in the body when you're undergoing these hormonal fluctuations as well?
What about the idea that the male brain is more vulnerable to more severe schizophrenia, autism spectrum, developmental disabilities, and the female brain is more sensitive to mood and anxiety problems? I remember learning that.
Yes.
Yeah. And again, I've wondered too, if assuming that that's roughly true, I've just assumed that was largely due to sex hormones, but again, maybe too simplistic.
Well, sex differences is not all based on sex hormones. Sure. In utero, your brain is exposed to maternal hormones, not just estradiol, progesterone, and allopregnanolone, but also high levels of the stress hormone cortisol. Also, the brain is developing based upon the genetics of both your parents, and all of that gets together. And it's amazing. It's just amazing to me that we don't have more issues with neurodevelopmental disorders, because somehow we're doing reproduction works. Somehow we are, creating offspring that seem to be able to function pretty well in this world. I think, though, that one of the issues is that we have so much stress in our world. And we know that stress for moms during gestation, I mean, you wouldn't believe how many women, pregnant women, are food insecure and housing insecure. And we know from animal studies that food insecurity in and of itself is a big stressor during pregnancy that can have impact not only on mom, but her offspring. We know from other studies, epidemiologic studies about famine and war and other kinds of stressors, that exposure early in life for mom and dad can have a lasting impact on their offspring. So it really isn't just about the hormonal fluctuations after we are born. It's about the in utero experience. It's also about mom and dad's current stress at the time of conception. And it's also about like what happened to mom and dad when they were younger. These messages do get passed on to the offspring. And there are suggestions in the literature that males and females respond differently to the passing of that information. And how it's passed may be different based upon whether you're a male child or a female child. Mm-hmm. So it's just fascinating. And again, all of this is really evolutionarily driven to some degree because we want survival of the species. And our environment has changed so much. I mean, just think about like when I was a kid, how different the environment is now.
No bike helmets.
No
sunscreen.
No sunscreen, no bike helmets. And believe it or not, I grew up in small town North Carolina, and when the mosquito guy would come by with the big tank of the pesticides, my sister and all of our friends would ride behind on our bicycles because it was like, oh wow, the mosquito guy is out there spraying for mosquitoes. I'm going to go right behind it. I mean, like, who does that today? But seriously, that was kind of like a thing. I mean, my parents let me go out into the woods and be gone for hours and just play on my own. And I never felt unsafe, you know? So we're asking our whole generations of people now to live in a very different environment. And quite frankly, evolution of the human body does not change so quickly as our environment. So I feel like some of what we're seeing right now is really kind of a mismatch between what we can really actually tolerate as human beings. The world has changed really quickly, and evolution doesn't change that quickly.
Mm-hmm. I was just going to comment on something I've been seeing in my clinic, and this is kind of a politically hypercharged topic, and I don't know if you feel comfortable commenting on it, but I'll just put it out there. I've probably had maybe 12 or 14 of my patients transition hormonally. Mm-hmm. And again, this is N of 12, N of 14. There could be observer bias, expectation bias. But I have seen in my own personal experience that when people transition with testosterone to male, they seem to have much less mood instability, more anger, more aggression, but less self-harm, less mood instability. And when I've seen people transition hormonally to female, I've seen more mood instability and more self-harm and sometimes even more suicidality. So again, but it kind of goes along with why, one of the reasons I want to meet with you. I just feel like the hormones are so complicated and are actually really changing the nature of how we experience the world and how we are. Mm-hmm.
Yeah. Well, it's obviously a complicated issue, and as I said before we got on, I am the chair of the Department of Psychiatry at a state institution, and so I'm really concerned as a psychiatrist, but I don't speak for the department nor the institution, but as a psychiatrist who's worked with people for almost 30 years now, it is complicated. I don't think that there's one size fits all in hormone use. And, one of the things that I will say that worried me a bit about hormone use, for transitioning is that, we want to get a certain phenotype physically, But again, just like we gave hormone therapy to postmenopausal women, years ago, it was like that forever feminine kind of BS, and you kind of say to yourself, why was that the most important thing? The brain is often the last organ to be studied with any type of treatment. It's like even birth control pills, for example. How many true studies do we have, even though we know that one of the main reasons that people will discontinue hormonal contraception is for decrease in sexual pleasure or interest and moodiness. And we also know that if you abruptly stop birth control pills, for example, that you're at increased risk for unintended pregnancy. I guess the issue is, for me, is that can we stop having the brain be the last organ to be considered when we're doing hormonal manipulations? What about the brain? We need to also study that. And there's some people that are really trying to do that, but I think it's going to be even harder. And I'm just hoping that we don't lose what we have at least gained so far when it comes to understanding hormone effects on the brain. So I guess I'll stop with that, other than to say that's the biggest concern for me is brain health. And I think that there's going to be a lot of distress in the coming months to years.
One of the things that's been most interesting about me following women through the lifespan is that even some of my women with really severe psychiatric illness, they usually, I won't say always, they usually do much better during pregnancy. And I've had women with a really severe schizoaffective disorder and bipolar 1 and some of the on clozapine. But during pregnancy, they mostly did quite well, and during the postpartum, often
didn't do well.
Terribly. But do you have any thoughts on, when women ask me about that, I say, well, my very general sense is that progesterone is very high during pregnancy, and progesterone I kind of think of as the kumbaya hormone. It's sort of peaceful and keeps everything sort of dialed down. And
some people.
Right. Yeah, right. I know. Here I'm speaking in generalizations. But do you have any thoughts on that? Is that, again, is this just my observer bias, or is it seeming true that even with pretty significant psychiatric illness, it sometimes seems to just calm down during pregnancy?
Well, there's a fair number of illnesses, not just psychiatric illnesses, that actually...
autoimmune.
Yes, autoimmune disease, seizure disorders, basically this... They say it's like a third. A third will stay the same. Even asthma, for example, a third will stay the same. A third will get better, and maybe a third will have an exacerbation. And again, I have no idea why that would be for all of these different disorders, but I do think that part of the thing that goes on during pregnancy is you have such high levels of cortisol, and we know that cortisol is really sort of dampens the immune system. So there's this relationship between high levels of cortisol. And again, chronic levels of high levels of cortisol across the lifespan is actually not good. It actually can, damage the central nervous system. But when you're pregnant for that 9 months, the thought is that, like, for example, autoimmune disease and maybe even panic disorder may be more related to, changes in allopregnanolone for these women, or decreases in PCO2 because, women tend to hyperventilate a little bit during pregnancy. So there's a lot of sort of physiologic changes that occur in pregnancy that for some people, maybe a third, and that may be the third you're seeing, is advantageous. They often don't like not being pregnant. I can't tell you how many people say to me, because I sort of do a hormonal history about when they felt their best, and they go, oh my God, I just loved being pregnant. And I'm always surprised if they tell me they didn't suffer postpartum depression, but because obviously you're no longer pregnant. But yeah, a lot of women say that that's where they felt best in their life. Mm-hmm. Other women feel miserable.
Yeah, right. I'm glad you mentioned that autoimmune thing. It made me remind me of a pet theory I have, which I'll just bounce off you. So I think it's really interesting, that during pregnancy, autoimmune diseases often get better. Psychiatric illnesses might get dialed down. But my pet theory is that there's something really, potentially really important overlapping with autoimmune and mood disorders. And so here's what I've been thinking. So maintenance ketamine is often monthly. Mm-hmm. Maintenance ECT is often monthly. Maintenance biologics, like infusions for autoimmune diseases, are often monthly. And I wonder if there's just something that's way more complicated than we understand right now for a lot of people with severe mood disorders, that it really is tied in with some part of the immune system, and thus there's some kind of reboot that needs, because I've also found that, because I do a lot of ketamine in my practice, that the folks with autoimmune disorders will often say they get a few days of really substantial relief post-ketamine. Mm-hmm. So I think ketamine is doing something anti-inflammatory or resetting the immune system, something. But I don't know, is that...
It's quite possible.
You're supposed to say it's a brilliant idea. I should study that. How did a private practice psychiatrist on his own in Fort Collins ever come up with that?
No. I mean, look, I think there are a lot of things that are cyclic. But when it comes to administering certain, certain products that have such disparate modes of action. And some of the modes of action, like the rapid onset of, symptom reduction with ketamine or with esketamine or, some of the psychedelics. Again, it's certainly not universal. And some people can be like one and done. Some people, I'm sure, don't need to come back for esketamine or ketamine on a monthly basis. But you may be picking up in your private practice on people for whom they do have more of a cyclic nature in their mood disorder for reasons that, quite frankly, could it be immune? Possible. I actually think there's a lot that we just don't really know.
Oh, this would be an interesting study. What if I just thought if we got like a highly sensitive C-reactive protein, which is a kind of general marker of inflammation.
Sure. Get
that, like in the people who do maintenance ketamine, do they have higher sort of baseline highly sensitive CRPs because they have more inflammatory involvement, which would maybe tie into my theory?
Well,
you can go.
No, I mean, CRP is just one measure of inflammation, and we're very interested in what happens when people are. So, for example, I collaborate with a basic neuroscientist, and she and I study together in humans and in mice changes and something called extracellular vesicles that basically are excreted by every tissue in the body and can be measured in the blood. So you can even measure sort of glial and neuronal origin EVs in the blood. And, but these are ways that your tissues can respond to the environment incredibly acutely. And, some send out a very acute signal and they could change very rapidly with, ketamine or esketamine. And some might be more tonic, that they're just less likely to change very quickly. And, they really do represent all body tissues. And so with, you can measure these extracellular vesicles, but then you have to do proteomics, and that's very expensive in order to try to get a sense, okay, well, there's a decrease or an increase in expression of this particular type from this particular tissue. And that's the kind of work that I think we're doing more of in psychiatry, to try and understand sort of more complexity, not just one system change, but for example, do these cells change that are being excreted by the liver or from liver origin or from brain origin or cardiovascular origin or immune system origin. And so I think that there's a lot that changes. And it's probably not one change. One of the things that we'll be doing is really, this is where AI comes in and people who really understand computational models much better than I do, that they can actually say, well, the profile of the person who's going to get better with esketamine is when you see this network change or this change in a lot of different signals, not just this one signal, but a lot of different signals that change acutely at a time. And so it's almost like what we consider a network analysis, where you're thinking about how things change with one another. Some things may go up, some things may go down. It's sort of like when people do brain imaging now, we're not so focused. I mean, I told you about the prefrontal cortex changing with estrogen. We're not as focused on one particular brain region now as we're focused on how brain regions communicate with each other. So these networks, and so it's much more complicated than just one measurement. And that's why I tend to try to measure lots of things. But, as a psychiatrist in private practice, you're amazing. Would you take more of our medical students? Seriously. I mean, you're the kind of psychiatrist that I love our medical students to
Well,
meet.
I stopped working with med students because none of them matched in psych. They would say, this was great rotation, I love this, and they all became like dermatologists and radiologists. So now I've devoted my teaching to psych NPs. So I'm only having psych NPs rotate with me.
Okay. Well, I'm going to work on you.
Okay.
Hey, you owe me. I did a
I
podcast.
owe you, I know,
you
but
owe
I
me. One medical student.
Oh, okay. Let's talk a little bit about postpartum, because I think, you were mentioning kind of evolutionary factors, and I've thought about this, I'm guessing you have too, that there's something just unbelievably cruel evolutionarily in the fact that for a lot of women, their psychiatric nadir, their horror time is after they have a baby. Mm-hmm. When you would kind of think like there would be selective pressure for a woman to be like, I got it, like I'm at my best, but obviously there's sleep pressures, there are huge hormonal fluctuations, but it is to me, it's a very strange and kind of sad phenomenon that I do a lot of prep work with my patients, like, okay, I just want to let you know you're at very significant risk of postpartum stuff. I'm going to stay with you. We're going to work through this, but this cruel reality that you get this beautiful little baby and you might just sink down into the worst place in your life.
Yes, no, that was the first area that I investigated, and the first clinical area in reproductive psychiatry was the perinatal period. And I do just want to say for your listeners, if you hear the term reproductive psychiatry, it's not solely perinatal mental health. I try to tell people it's the whole female reproductive lifespan. If you have 2 children, you spend less than 4% of your entire lifespan pregnant or postpartum, and that's if you have 2 kids. And so we do want to focus on women across the lifespan. But I did start in the perinatal period and working with women with postpartum depression, and it was incredibly sad. And it was one of the things that got me so interested in hormones because, when you can put a biological, even if we don't know the exact mechanism, and maybe there's no one exact mechanism, that women come to postpartum depression and the experience of postpartum depression in different ways, biologically meaning. Just to know and be able to tell somebody, explain the hormonal flux, say why this might be a trigger for you with these hormonal changes. It all of a sudden takes it out of the realm of, oh, I'm going to be a bad mother, mm-hmm. or I'm so ungrateful, I heard all kinds of things. And, and it also helps the family, I think, to go, oh, this is temporary. This will pass, and you're going to help me help my wife feel better or my daughter-in-law feel better. And so it takes out some of the stigma related to it as well. But I have to tell you, given what I was saying before about the fantastically flexible female brain, I'm kind of surprised that not more women become depressed and psychotic in the postpartum period. Quite frankly, it's amazing to me that the brain can actually tolerate this level of change in in so many women. I mean, it kind of blows my mind. So while it's incredibly sad if this happens to an individual, and it happens to many, many women, it's not the majority. And that's sort of shocking to me from a hormonal perspective. Not shocking from an evolutionary perspective, but is shocking from a hormonal brain perspective.
Yeah. Well, it's kind of like in medicine, the more and I think in science, the more you understand things, the more you are just in wonder that it just doesn't all fall apart. Like, why don't we all just clot out or bleed out, or or that our mitochondria don't just fly apart? All this, like, you can see where people kind of think, like, what's
holding this
right?
all
What's
together?
holding this all together?
Because
or the immune system. Are you kidding me? Like, how the heck does that ever work?
Oh, I know. Yeah. I know. I mean, the human body is. It's one of the reasons why I stayed in academia. And to me, the brain is the most interesting organ in the body. I just am fascinated about it every single day, and it's so critical to all areas of health. It's one of the reasons I decided to become a chair of a department of psychiatry, is that my career mission is to promote the centrality of the brain with respect to all areas of health. And so I'm constantly telling, like, the Department of Surgery chair or OB/GYN orthopedics, and luckily here everybody gets how important the brain is, but I looked at a lot of chair positions across the country, and people didn't get it. I mean, they really so people here appreciate the importance of the brain and understand that, the practice of psychiatry and psychology is not voodoo. That even when we're doing psychotherapy, and so you're not actually giving a medication, to me, you're still doing neuromodulation, because you don't change behavior without changing the brain.
Yeah. Menopause and hormone replacement is such a interestingly controversial topic right now, and so I have a lot to say about this. I want to hear what you have to say. One thing I've been thinking of, it seems like a bit sort of paternalistic, misogynistic. I'm just imagining if we told men as they aged into their 50s, 60s, 70s, okay, your testosterone's low and you have no libido and your muscles are flabby and you have no energy and you're kind of depressed, but that's just part of getting older, sir. Or even different, like we told women, why don't you go on testosterone for a few years in your 50s, get a little boost to that libido, a little energy, build up a little muscle definition, but then you should go off it and let your sad little gonads just shrivel, and just become the weak, diminished old man that you should be. Yeah. I mean, men would lose their minds. But that's but that's, I think, what we have been telling women for so many years, like, well, no, this is natural and you should just put up with this diminishment of your hormonal milieu. And what I tell my patients, again, I'm curious what you'll say to this, I often tell my patients, look, menopause is not natural, meaning for the vast majority of human history, we were dead way before menopause. Like, menopause is really is really an outgrowth of modern medical science. And we act like it's natural, but, menopause is the ovaries burning out, just like andropause is men's gonads, testes burning out. And boy, if you want to look at a group of men who are grateful, almost on their knees thanking me, it's men with low T that I start them on testosterone.
Yes.
It's definitely one of the most just validating, wonderful things I can do is to help restore men's testosterone levels. Yeah. And same thing with hormones, but yet I get so much pushback from, if I talk to gynecologists or PCPs, like, hey, I want to start this woman on HRT, they're like, well, it's going to cause an increase in breast cancer. Yeah, but psychiatrically, it's going to be good, and bone health and cardiovascularly. But so anyway, this is my long-winded way of saying I'm just baffled that this is even a topic. And again, I know there's some big old studies that we can touch on, but really in 2025, the fact that we're wondering, like, should we actually augment and replace hormones for men or women as they're aging to try to improve their health and functioning. I just can't even believe that we're still talking about this. Okay, now I'll stop.
Okay. So I'm with two minds on this, Craig. I mean, I totally understand what you're saying. And as a psychiatrist, I do prescribe hormones, which is not a common thing for a lot of psychiatrists. But, I really think about the whole person. I think I take a careful history. I mean, I'm always thinking about the pros and cons. I mean, there's no hormone that's the panacea, just like there's no medication. There's no, immune suppressant or painkiller or anything like that is a magic bullet for everybody. And this is where I get back to this whole concept of personalized medicine, that we need to be thinking about each individual and what are their needs. And so, for example, there are some men that they're on the cusp when it comes to, quote unquote, for your age, your testosterone is still in the normal range. But for that guy, that might be too low for them. I mean, that guy might be having symptoms, even if it's, quote unquote, in the low normal range. I mean, it's the thing about, thyroid supplementation. Oh, you're kind of on the cusp. I always feel like, well, let's do the experiment.
Who wants to be on the cusp?
Yes.
Of that? It's like, I want to be on the top end. I want to be riding the front end of that wave. Oh, I just squeaked in on the back.
Yes, but again, everything has its risk and benefits. Yeah. And so as physicians, we are supposed to do no harm. And so we have, in some areas we have good science, in some areas we have science that is just not clear. And so where sometimes the science is a little bit less clear for me, I often try to think about that as where I need to practice the art of medicine, because I don't have a hard and fast study or multiple studies saying this that convince me. And a lot of times when it comes to hormone therapy, it's like all over the place. You mentioned breast cancer. Well, if you looked at the Women's Health Initiative study and you just looked at the group that just got estrogen, not the estrogen and the progestin, and again, they were not giving 17-beta estradiol in that study. They were giving conjugated equine estrogen. But even in the estrogen-only group, you did not see an increase in breast cancer. And so the bottom line, and if you look 14, 15 years later, the people who participated in those studies, there was not an increased risk of all-cause mortality or breast cancer-related deaths in the group that were randomized to either of the hormone therapies that were in that study versus placebo. So it's like, we get all excited and anxious about a finding, and then, years later you look back on it and you go, oh, God, a lot of women suffered because we just ripped them off the hormone therapy, and maybe those women were the hormonally sensitive group who needed it, And so I agree with you. It's been problematic. And I think you have to look at the person in front of you and say, this is really working for you. This is really helping you. I will monitor you along with your other doctors. And if you want to stay on it 10 or 15 years, okay. I'm not going to say, oh my gosh, you can only do 5 years and whip somebody off. Mm-hmm. I had a woman who's a neurologist from another state referred to me here. And, she had undergone a natural menopause at the age of 40. Well, that's considered a premature menopause. Her gynecologist would only give her 5 years of estradiol. So she said, oh, you can only take estradiol from 40 to 45. And I was like, where did that come from? Seriously? Oh, you mean that, the recommendation is that, for women who are postmenopausal that we do 5 years? Well, that might have been based on studies of women that were 52 when they became postmenopausal, not 40. Mm-hmm. So it's just that there's a lot to be done in this area.
Yeah. Well, it seems like you and I are in this small minority of psychiatrists who prescribe hormones. Mm-hmm. One, I find it really rewarding and interesting. And two is, when I discuss it with other psychiatric folks, and they say, wow, I can't believe you do that. That seems scary. And I will often say something like, well, you're prescribing aripiprazole or Abilify or, loracetone or clonazepam, Klonopin. Like, what is riskier? Klonopin or estrogen? Are you kidding me? Yeah. Really, but in psychiatry, I think we all just get used to prescribing these really serious meds that can have serious and even fatal downsides. But to give someone a hormone that the person actually has in their body, again, not that it couldn't cause problems, but
Well, again, a lot of medicine is now like, you stay in your lane. You're not an endocrinologist, you're not a GYN, and this is the purview of the endocrinologist and GYN, well, or the internist or what have you. And, as much as we know in psychiatry that a lot of depression and anxiety is treated in primary care with all the medications that you and I use. And we all want that. We want integrated care because we know that a lot of primary care docs can do that. So I have no problem with people in other fields prescribing a lot of the medications that we do. And here in Colorado, if you don't have a psychiatrist around as a primary care doc, you're all there is. I feel like just the opposite. I'm the psychiatrist who really has to look at my patient and really think about holistically, what does my patient need? So if I think they need thyroid hormones, I'm going to supplement them.
Me too.
Exactly. I mean, because again, all of these hormones are affecting my organ of interest, which is the brain. And I am responsible for this person's brain health as their psychiatrist. And as a psychiatrist, I still feel what's really important is that I think about all the organ systems. So yes, when I'm prescribing, I'm not only thinking about why this might be good for the brain, but like you said, for the bones and for the immune system or from their, other body tissues, like, for example, the epithelial cells in the eye. One of the reasons, they're very estrogen sensitive. One of the reasons why, ophthalmologists will see women coming to see them at midlife and beyond with incredibly dry, itchy eyes. Again, it's a postmenopausal phenomenon for a lot of people. So it's like all these other doctors are looking at things that are related to hormones in one way, shape, or form, in my mind. And so we have to, I guess, maybe not be so worried about being so strictly in our lane. I think there are things that we have to be careful about with, potential for malpractice and things like that. So I make sure I document just like a GYN would when I'm giving hormone therapy.
There's a whole subset of my patients, women, when they hit usually late 40s, they come in and often very sad and somber, and they say, Dr. Heacock, I'm developing early dementia. I think I have early Alzheimer's. Or I have late onset ADD. And I smile, and 9 times, not 100, 9 times out of 10, they are going into menopause. They get on a estradiol patch, and they come in, I'm smart again. My dementia's gone away. I guess I'm going to be okay. And they just can't believe it because they're like, well, I didn't think estrogen was important. I thought it was kind of a, maybe sexual functioning hormone to protect my bones. I didn't know it had anything to do with my brain or my mind. But I feel like I've fixed, quote unquote, fixed many, many cases of early dementia with the estrogen patch. It's what's more rewarding than that? Outside my scope of practice, like what?
Well, I'm sure their sense of well-being and their mental health was a lot better after that. So in that vein, I actually, in my practice, started seeing a lot of women, again, who had undergone oophorectomies for cancer risk reduction, or they had had cancer and basically had done the oophorectomy and mastectomy and that kind of thing. And they were basically saying, I can't think my way out of a shoebox. And so I was at Yale at the time, so this was pretty early in my career. And I reached out to someone who was in the department that had focused a lot on ADHD. And I reached out to Tom Brown and I said, Tom, are you seeing a lot of middle-aged women or women who've undergone oophorectomy coming to you with what sounds like symptoms that could be like ADHD, but they've never been diagnosed before? So he and I started talking, and he was seeing a lot of these same women. And the women that were coming to me, because I'm a psychiatrist, and to him as a psychiatrist, were pretty severely affected. It was really impacting their quality of life, this executive functioning kind of stuff. And And again, they didn't come in saying, "Oh, Dr. Epperson, I have executive functioning difficulties." They just came in and said, "What is going on with my brain? Why can I not remember anything? Why do I go to a party and I can't, I just can't, remember somebody's name, or I feel like an idiot when I'm rounding with the residents on the unit because, I know what I want to say and I can't say it. I can't pull it out of my brain, and I just don't feel motivated to do the things I used to do, or, I'm just not as focused, or seem more distracted. I mean, that all sounds like ADHD, doesn't it? So a lot of the women that I saw couldn't use estrogen. And I have seen some of the brain fog respond to estrogen, but I haven't seen as many women with the more sort of significant sort of executive functioning difficulties get as better with estrogen as I would like. And I also was seeing women who couldn't take estrogen. So I began studying psychostimulants in this population. And again, I randomized women to placebo or the psychostimulant only if they came in with a certain severity of symptoms, because that's what you have to do in a clinical trial. And they did not have any childhood history of ADHD, because I really wanted to see, could women tolerate at midlife a psychostimulant? In this case, it was lisdexamfetamine, and sort of what symptoms would get better if they didn't have the diagnosis of ADHD. So, of course, obviously, I was using, as they say, the medication off-label, but it was research. So, and again, within 3 weeks of being on the lisdexamfetamine versus the placebo, we saw a significant reduction in these kind of quote-unquote ADHD-like symptoms, both in women who had undergone a natural menopause and had onset of these symptoms, and women who had undergone the oophorectomy. So I think that there are other options for women as well, if particularly those who might not be able to try estrogen.
Yeah. We're reaching the end of our allotted time. I just saw your assistant just wave her hand through the window, kind of pointing at her watch. So, but I just want to wrap up. We have a lot of psychiatric clinicians who listen to the podcast, and I wonder if you have any, words of wisdom or thoughts about hormones and psychiatry and
Sure.
psychiatric illness that just sort of take home points for people who are working in the trenches with this.
Well, I really think that, first of all, psychiatrists should not see hormones as outside of their scope of practice. And if they don't feel comfortable thinking about hormonal manipulations in their patients, then there are ways, like, for example, in the Menopause Society has a certificate program that people can do online and really sort of educate themselves about, how does one use hormone therapy? How do I do it safely? Who might I be thinking about giving this to? For people who are younger in their careers, if you're still a resident, there's fellowship programs that people can do. You can, join up in a practice where the people already have this expertise. I do think it's very important to also, even if you're not going to dabble in hormones as psychotropic medications, because they are, I think it's critical to understand how to do a good reproductive assessment and really try to understand the patient. What hormones are they taking, if they are or aren't taking hormones, whether they might have even a hormonal issue like polycystic ovarian syndrome, which is also very, very common and comorbid in people with psychiatric issues. So become sophisticated in your assessment of the patient. And if you feel like you're over your head and that you're like, okay, hormones probably are somehow involved in this, there are a lot of people in this state that are very interested in this, and make a referral. Just get a second opinion.
Yeah. So the take-home message: become sophisticated.
In one way or another. But dip your toe, at least in understanding how do you assess for premenstrual disorder? How do you assess for perimenopause onset for cognitive problems?
Yeah. Well, this has been really fun. Way worth the drive. Thank you for carving time out of my schedule.